Hi everybody, and welcome to our module on coagulopathies. An easy way to group bleeding disorders is to think about those that involve the coagulation cascade, those that involve platelets, and those that involve both. So in this module, we're going to focus on bleeding disorders where there is an abnormality of the coagulation cascade. These disorders are often called coagulopathies, and this includes hemophilia and vitamin K deficiency and a few others. In another module, I'll talk about platelet disorders, including disorders that involve both platelets and coagulation like these down at the bottom of the screen. Before we talk about coagulopathies, I want to review some of the tests that can be used to assess hemostasis. And the first test I'm going to talk about is the bleeding time. This is a test of platelet function. This is an old test. It's rarely done in the modern era. The way a bleeding time used to be performed is by making a small cut in the skin on a patient's arm. Then filter paper was applied and removed at regular intervals until the filter paper was clear of blood, which indicated the bleeding had stopped. You would then record the time it took for bleeding to stop, and that was the test called a bleeding time. This is a test of platelet function because this type of very superficial bleeding on the skin is heavily dependent on normal platelet function in order for the bleeding to stop. So the platelet time would rise when there was a problem with the platelets. This slide shows the coagulation cascade, which I review in detail in other modules. What I want to point out here are the tests that can be used to assess the coagulation cascade. The first one is the PTT, which is the activated partial thromboplastin time. This tests the intrinsic pathway of activating the coagulation cascade. In this test, you add the plasma that you want to test to a negatively charged substance, usually silica. Silica will activate factor 12, and this will initiate the intrinsic pathway. You then record the time it takes for blood to clot in a test tube. Normal is about 30 seconds. The PT, or the prothrombin time, is a test of the extrinsic pathway. In this test, you take a sample of plasma that you want to assess and you add tissue factor. Tissue factor then initiates the extrinsic pathway, and you measure the time it takes for a fibrin clot to form. Normal is about 10 seconds. Now, most labs convert the prothrombin time to an INR, which stands for International Normalized Ratio. This is where you divide the patient's PT by a control PT. Normal is 1, and therapeutic on Coumadin, for example, is about 2 to 3. And then there's one final test of the coagulation cascade. It's called the thrombin time. This is also an older test, not used much in the modern era outside of research circles. In this test, you take a sample of a patient's blood and you add thrombin and you record the time it takes to form a clot. Because thrombin is very far down the coagulation cascade, the only way this test will be abnormal is if there is an inhibitor of thrombin in the plasma or if the patient has a very low fibrinogen level. Before we get into specific coagulopathies, I want to mention a general rule of thumb about types of bleeding. When bleeding problems develop from platelet abnormalities, the bleeding tends to be relatively superficial. So this may present as mucosal bleeding, skin bleeding, and the characteristic finding is the presence of petechiae on the skin. These are petechiae shown on someone's skin on the screen here. You can see that they are small red dots, and this is what happens when there are platelet abnormalities. When there are abnormalities of the coagulation factors, on the other hand, the bleeding tends to be deeper, so it can occur in the joints or it may be in the deep tissues. Now, this is just a rule of thumb, but this can be helpful, especially when you're trying to sort out board questions. So the first group of coagulopathy disorders that we'll discuss are the hemophilias. These are all X-linked recessive diseases, so they tend to occur more commonly in males. They result from gene mutations that often run in families, although you should know that they can occur de novo, so the absence of a family history of hemophilia or bleeding does not rule out a hemophilia disorder. There are two common hemophilias. The first one's called hemophilia A. It's a deficiency of factor 8, and I've always thought of hemophilia A as hemophilia 8, just to keep that straight. The second hemophilia is less common. It's called hemophilia B, and that's a deficiency of factor 9. This is also sometimes called Christmas disease. On the screen here is a picture of Alexei Nikolaevich. He was the son of the last Tsar of Russia, and if you've never heard the story, he was born with hemophilia, and he suffered from recurrent bleeds into his joints that were very painful, and he was a very sick child. For this reason, his mother brought him to a mystical healer named Rasputin to try and make him better. Rasputin couldn't heal him, obviously. This was in the early 1900s, and there was no therapy for hemophilia. But the fact that the royal family was using this mystical healer was one of the factors that led the people to lose faith in the Tsar and the Russian monarchy. So when you look at a map of the globe and you see the Soviet Union, you can remember that hemophilias played some small role in leading to the collapse of the Russian monarchy and the Russian Revolution and the establishment of the Soviet Union. Patients with hemophilias present with spontaneous or easy bruising. They also commonly present with recurrent joint bleeds, much like Alexei Nikolaevich had. The screening test for hemophilias is the PTT or prothrombin time. It will be prolonged. And that's because factors 8 and factor 9 are both part of the intrinsic pathway. We'll talk more about that in the next slide. Importantly, the other coagulation and blood clotting tests will all be normal. So the PT will be normal, the bleeding time will be normal, and the platelet count is normal. Here's a map of the clotting cascade from our module on coagulation. Factor 9 and factor 8 actually work together. Factor 8 is a cofactor for factor 9. They are both part of a multi-component complex that includes a phospholipid surface and calcium and converts factor 10 into factor 10A. Deficiency of either factor therefore leads to a similar presentation because this complex here cannot convert 10 into 10A. They're both part of the intrinsic pathway, which begins with factor 12. The extrinsic pathway, which begins with tissue factor, will remain intact and will be normal in hemophilia. In the modern era, the treatment of hemophilia is replacement factor 8 or factor 9. Children and the parents of children with these conditions learn how to administer this drug, often by placing an IV. Sometimes the children receive scheduled dosages. Sometimes they just take a dosage when they're going to be out on the playground and doing things where they might get banged up. There are some other treatments that can sometimes be used, and you should know about these, especially for step 1. One of them is called desmopressin. It is an analog of vasopressin or ADH, but it has no pressor activity, so it won't raise the blood pressure. It can be used in mild hemophilia A, and the reason is because it increases von Willebrand factor and factor 8 level. Von Willebrand factor and factor 8 are both stored in the Weibel-Palade bodies of endothelial cells, and desmopressin triggers their release so that the levels will rise in the plasma. Desmopressin also has vasodilating properties, and if you remember this, it helps you remember the side effects. It can cause flushing or a headache. It's also used in some other conditions. It's useful in von Willebrand disease because, as I just told you on the last slide, levels of von Willebrand factor will rise. In addition, it's often used as a mimic of ADH. This is helpful in central diabetes insipidus. It's also sometimes administered to children who suffer from bedwetting. It will decrease their urine volume if they take a dose right before bed, and therefore they're less likely to wet the bed. Another drug that can be used in hemophilias is aminocaproic acid. This is an antifibrinolytic drug. It inhibits plasminogen activation so that plasminogen does not convert into plasmin. And as you know, plasmin breaks down fibrin clots. So if you administer this drug, there's less breakdown of formed clots. This allows whatever factor 8 or factor 9 is available in the patient's plasma to work more effectively because plasmin is not breaking down whatever fibrin clots can be formed. Another therapy for hemophilia A is cryoprecipitate, which is often just called cryo. This is an obsolete therapy for hemophilia A. It used to be used before factor 8 was readily available. Cryoprecipitate is the precipitate that forms when fresh frozen plasma is thawed and then separated from plasma by centrifugation. It contains lots of factor 8 and also lots of fibrinogen. It also contains some factor 13 and some von Willebrand factor. So before there was factor 8 available, this would be used as a source of factor 8. Nowadays, it's often used as a source of fibrinogen. So in disorders like disseminated intravascular coagulation or massive trauma with blood transfusions, patients can become low on their fibrinogen level because so much is being consumed by clot formation. So you can administer cryoprecipitate to try and replete their fibrinogen stores. The next coagulopathy we're going to discuss is the presence of a coagulation factor inhibitor. These inhibitors are antibodies that are directed against the clotting factor, and they either inhibit the activity of the clotting factor or they increase its clearance from the plasma. By either mechanism, they will lower the efficacy of that particular clotting factor. And the most common inhibitor is one directed against factor 8, and this has a clinical presentation very similar to hemophilia A with recurrent bleeding and joint bleeds. These often occur in association with certain conditions, so they can occur in association with malignancy or autoimmune disorders. In either of these conditions, there are lots of antibodies that can potentially develop as a result of the disease. They're also common in the postpartum state. And it's important to distinguish these from hemophilia because unlike hemophilia A, these can be treated with prednisone as an immunosuppressant. So as I said before, the clinical presentation can look just like hemophilia A. There's deficient activity of factor 8. This can lead to bleeding and a prolonged PTT. So how are you going to tell the difference between a coagulation factor inhibitor and hemophilia A? And the answer is you need to perform something called a mixing study. In a mixing study, you mix a patient's serum with normal serum to see if the PT and PTT will correct back to normal. A mixing study is based on the principle that when clotting factors are 50% of normal, you will get a normal PT or PTT level. In other words, the clotting factor levels need to be less than 50% in order for the PT or PTT to become prolonged. So let's look at the drawing I've made on the screen. Let's imagine that we have a patient with the worst case of hemophilia A in the world. They have no factor 8 at all. This patient will obviously have a very prolonged PTT. Now let's imagine that you mix that patient's serum with normal serum, and all these blue dots represent little molecules of factor VIII. What you will then have is a mixture that is 50% of normal level of factor VIII, and 50% of normal is enough to normalize the PTT. So in a patient with hemophilia, the PTT will correct when you mix it with normal serum by this principle. And of course, many patients with hemophilia A do not have no factor VIII. They have some in their plasma. So this makes it even more true that when you mix it with normal serum, the level will be 50% or greater, and that will yield a normal PTT. Now let's imagine we have a patient who has an inhibitor of factor VIII. They have normal factor VIII levels, but all these little red triangles represent an inhibitor. They will also have a high PTT, just like the hemophilia patient. However, when you mix this patient's serum with normal serum, the PTT will not correct. It will remain prolonged. And that's because there are all these inhibitor molecules floating around in the bloodstream, and they will inhibit the factor VIII in the normal serum, just like they did in the patient's serum, and the PTT will remain prolonged. So that's how you use a mixing study to tell the difference between hemophilia and the presence of a clotting factor inhibitor. Our next coagulopathy is a deficiency of vitamin K. This will result in bleeding. The reason vitamin K deficiency results in bleeding is because several clotting factors are so-called vitamin K dependent factors that depend on vitamin K for normal levels and function. And the vitamin K dependent factors are factors 2, 7, 9, and 10. The important laboratory findings in a patient with a vitamin K deficiency are an elevated PT-INR. I've bolded this because this is the most sensitive test to vitamin K deficiency. I'll explain why in a minute. You can see an elevated PTT, but this is less sensitive, and then you will see normal bleeding time and normal platelet levels because the platelets are not affected by the vitamin K level. If we go back to our map of the coagulation cascade, the vitamin K dependent factors are factor 2, factor 7, factor 9, and factor 10. And you can see that these are involved in both the intrinsic pathway and also the extrinsic pathway. However, it turns out that factor 7 has the shortest half-life of all of these factors. That means that the factor 7 level will be the first level to fall when a patient becomes vitamin K deficient. That makes the extrinsic pathway, which is tested by the PT, the much more sensitive test to vitamin K levels, and therefore that's the better test when you're looking for a vitamin K deficiency. In the biochemistry modules, I have a whole section on vitamin K. I'll just summarize some key points here. A dietary deficiency of vitamin K is very rare, and that's because GI bacteria produce sufficient quantities of the vitamin. Common causes of a vitamin K deficiency include warfarin therapy. This isn't really a deficiency of the vitamin, but warfarin antagonizes the activity of vitamin K, and therefore it makes you relatively deficient in vitamin K activity. Patients who take antibiotics often become deficient in vitamin K. That's because the antibiotics can deplete the GI bacteria. Newborns have a sterile GI tract, so they're usually given an injection of vitamin K so that they don't develop a bleeding disorder. And then finally, vitamin K is a fat-soluble vitamin, so if you have any form of malabsorption that leads to poor absorption of fat-soluble vitamins, you can become vitamin K deficient. Another potential cause of a coagulopathy is a blood transfusion. If a patient receives a large volume of blood transfusions, for example after a major trauma, this can lead to a dilution of the clotting factors. Packed red blood cells, which are used for blood transfusions, are devoid of plasma and platelets. These are removed after collection. In addition, many patients who require large volume transfusions also receive saline or IV fluids. These do not contain clotting factors, so all of this can work together to dilute the clotting factors and result in a coagulopathy. This is often treated by administering fresh frozen plasma, which is plasma that contains all the clotting factors. Our final coagulopathy is liver disease. In liver disease, there can be loss of clotting factors. In advanced liver disease, the liver can fail in its synthetic functions. This can lead to decreased synthesis of the clotting factors. Most clotting factors come from the liver. The one exception is factor VIII, which is produced in endothelial cells. This can lead to a rise in both the PT and the PTT. However, the PT is more sensitive for the same reasons I mentioned with vitamin K deficiency. The vitamin K dependent factors are synthesized in the liver, and therefore the first level to fall will be the level of factor 7, which is involved in the PT test. Thrombocytopenia is also common in liver disease. There can be decreased hepatic synthesis of thrombopoietin, which stimulates platelet production from the bone marrow. In addition, there's often platelet sequestration in the spleen from portal hypertension. And that concludes our module on coagulopathies.